Hello, my name is Eleftherios Diamandis and I work with the University of Toronto. I am absolutely delighted that I have a chance to give a presentation to EDRN. As many of you know, I gave many presentations over the last 20 years. This time, I will talk to you about discovery and validation of serological personalized biomarkers of recurrence using multiplex proteomic technologies, and this is in collaboration with Dr. Robert Bast, and the theme, of course, is ovarian cancer. Our vision here is that tumors, ovarian tumors, secrete or shed distinct array of proteins into the blood, which encompass the tumor heterogeneity, as is shown here graphically. And we believe that by quantifying the serum proteins that originate from the tumor with advanced proteomic technologies, we can predict sensitively changes in tumor load and detect relapse by using these profiles of proteins. We show here a number of ovarian cancer patients, and below we denote that biomarker A is only produced by 5% of the patients due to heterogeneity. Biomarker B is expressed only by 20% of the patients for the same reason. Biomarker C is expressed by 30% of the patients. Biomarkers D are 10% of the patients, and so on. We also believe that by combining all these biomarkers together and creating a panel, we may be able to achieve very high sensitivities and specificities. We speculated that this personalized biomarker works for only 5 to 30% of the patients, but if we screen the patients with high throughput technologies for a comprehensive panel of personalized biomarkers, we can achieve sensitivities that far exceed the sensitivity of CA125 and AG4 alone or a combination for detection of relapse. Here we reiterate our hypothesis. Hypothesis number one is that, as I said already, we want to build a panel of personalized ovarian cancer biomarkers that will provide personalized marker combinations for tracking the tumor burden in each patient. And hypothesis number two is that this combination of personalized biomarkers will be able to detect relapse much better, with much better sensitivity than CA125 and AG4 alone. We were first interested to make sure that the high throughput proteomic technologies we will be using for this exercise are analytically reliable. The technique we use is commercially available by Olink Proteomics in Boston and is called proximity extension assay. This technology has the capability to quantify over 1,000 proteins in serum by using minute volumes such as 50 microliters. What we did, we have shared with Olink blinded samples of a male and a female volunteer, and we quantified over 1,000 proteins in blind, and then we correlated the results of the two measurements. And as you can see, both the male sample and the female sample, for the 1,000 proteins that we quantified, there is an excellent correlation. We concluded from this analysis and other data, of course, that the paired technology of Olink is highly sensitive, works with serum, and is precise enough to be used for clinical use. In the first discovery experiment by using proximity extension assay proteomics, we selected 30 high-grade serum carcinoma patients with serum samples collected at 4 time points before surgery, after surgery, and at 2 times post-chemotherapy, as is shown here. 25 of these patients had clinical recurrence within 12 months, but we selected 8 patients from these 25 who didn't have any elevations in CA-125 and had imaging confirmed relapse. We also used 5 patients with no clinical recurrence for comparison. For these 30 patients times 4 samples, we quantified over 1,000 proteins by using the paired technology of Olink, and we analyzed the data, and I will show you later what we found. It is important here to note that we also included 27 patients who had 3 samplings each, normal people, because we wanted to find out the natural variability of these biomarkers, and we calculated the percent variability and the relative change over time. We use this as a baseline change to make sure that the patients that we study have higher reference interval changes than the controls that we used. It is important to note here that in the patients who have no elevations in CA-125, but they had relapse, we were able to identify 7 out of 8 by using our novel panel. Next, we wanted to validate the ability of our top candidate personalized tumor markers to predict ovarian cancer relapse in an independent cohort of patients. For this purpose, we selected high-grade serum carcinoma patients who are platinum resistant and relapsed within 6 months. Those were 9 patients. We selected 25 patients who were platinum sensitive and relapsed within 1 to 3 years from the last dose of chemotherapy, and 5 who were long-term survivors, greater than 7 years survival and free of disease from the last dose of chemotherapy. For each one of these 39 patients in total, we have 4 to 8 sample collections before surgery, at surgery, and during the chemotherapy cycles. For these patients, the 234 samples, we quantified 644 proteins with the proximity extension assay technology of Olink, and included 21 of our 23 candidate biomarkers that we identified before. Then we analyzed the data, and the data will show you right now what we found. As I have shown you before, this is the list shown here of the personalized biomarkers. These are the patients that I described, 9 with platinum resistance, 25 with platinum sensitivity, and 5 patients who had no relapse, and the value of change with time of each biomarkers for each patient, as I explained before. And you can see again that this is the sensitivity that we got for each one of the markers, which ranges from about 40–50% down to about 10%, as expected. But the important thing is that if we combine the results of the 21 personalized biomarkers, of which 10 were the validated markers from the first study and 11 newly identified, we were able to identify here 93% of the patients who relapsed, and most importantly, most of the patients who were platinum resistant and CA-125 was not informative in many of them. We identified 93 to 95% of those patients by using our panel of 21 biomarkers. I am sure you will want to know what is the nature of these 28 to 30 personalized biomarker proteins, and I show you here that among all these personalized biomarker proteins, 15 proteins were implicated in relation to ovarian cancer therapeutic targets and are shown in green font, and 12 proteins have been shown to demonstrate genetic variations in various cancers as shown in purple. So the markers that we identify as personalized have biological relevance in ovarian cancer. I would like to close this presentation by providing you with some conclusions and future perspective. As I have shown you, we identified 23 personalized candidate ovarian cancer biomarkers that decrease at recurrence to enhance patient treatment strategies. Our findings reaffirm the high heterogeneity of ovarian tumors, whereas the diversity of ovarian cancer tumors may be captured, in this case, not by genomic techniques, but by an array of personalized proteinaceous and circulating biomarkers. Our study unveiled the use of an innovative proteomics method, proximity extension assay from Olink, for biomarker discovery in various diseases, especially applicable to personalized medicine. We hope that with a larger cohort of longitudinal sample patients, we will aim to assemble a panel of 21 personalized markers for individualizing ovarian cancer surveillance. We are already working with Olink, who is constructing our 21 panel, which can be used simply, quickly, and at reasonable cost of about $100 per sample to test patients longitudinally for earlier and more robust detection of biochemical and clinical relapse. I would like to end this presentation by thanking all the members of my research laboratory, past and present, but especially Dr. Annie Ren, who has developed this technology as part of her PhD thesis. Last but not least, we are very encouraged that Dr. Robert Bast has agreed to collaborate with us not only on constructing the 21-member panel, but also for validating this panel as part of his EDRN studies. Thank you very much for your attention.